Welcome to the Transdermal via Sublingual podcast. In today's episode, we will delve into the effectiveness of sublingual and topical compounded bioidentical hormone replacement therapy in postmenopausal women. Stay tuned to learn more about this fascinating topic and make sure to subscribe to our podcast to stay updated on the latest insights. In today's episode, we'll cover the effectiveness of sublingual bioidentical hormone replacement therapy in reducing symptoms in postmenopausal women, the differences between oral and transdermal estrogens, and the effectiveness of transdermal hormone replacement therapy in preventing postmenopausal osteoporosis and improving metabolic risk markers.
Hey there. Today we're going to dive into a recently published study that evaluated the effectiveness of sublingual and topical compounded bioidentical hormone replacement therapy for the treatment of vasomotor, mood, and other quality of life symptoms in postmenopausal women. Previous studies have shown that compounded bioidentical hormone replacement therapy can be effective in improving menopausal symptom relief, but there hasn't been much research into the effectiveness of different routes of administration. The objective of this particular study was to fill that gap and determine the effectiveness of sublingual and topical bioidentical hormone replacement therapy. So what did they find? Well, the study was a prospective, observational cohort study of women over the age of 18 who received a compounded sublingual or topical bioidentical hormone replacement therapy preparation between January 1st, 2003 and October 1st, 2010 in a community pharmacy. They collected data on patient demographics, comorbidities, hormone regimens, and therapeutic outcomes. Patients rated their vasomotor, mood, and quality of life symptoms at baseline, at 1 to 3 months follow-up, and at 3 to 6 months follow-up. A total of 200 patients met the study criteria, with 160 receiving topical therapy and 40 receiving sublingual therapy. The majority of sublingually treated patients, 70%, received an estrogen combination and 100% received progesterone. Nearly half, 43%, of the topically treated patients also received an estrogen combination and 99% received progesterone. The results showed that patients who received sublingual therapy experienced significant reductions in moderate to severe symptoms for a variety of areas, including hot flashes, night sweats, irritability, anxiety, emotional lability, sleep disturbances, memory loss, fatigue, and libido. These reductions were seen at both the 1 to 3 month and 3 to 6 month follow-up periods. On the other hand, patients who received topical therapy did not experience significant symptom reductions at 1 to 3 months follow-up, but did experience significant reductions in emotional lability, irritability, and night sweats at the 3 to 6 month follow-up period. Overall, the study suggests that sublingual bioidentical hormone replacement therapy is more effective in reducing vasomotor, mood, and quality of life symptoms experienced in postmenopausal women than topical therapy. So there you have it. Hope this summary was helpful in shedding some light on this interesting study. Have you ever wondered if all estrogens are created equal? Well, according to a review comparing oral and transdermal therapy, it seems that there are significant differences between the two types of estrogen. These differences could impact the clinical efficacy, potential side effects, and overall risk profile of different hormone therapy options. But what exactly are these differences? When it comes to hormonal bioavailability and metabolism, oral and transdermal estrogens seem to have different effects. Bypassing hepatic metabolism, which is when medications are processed by the liver, seems to result in more stable serum estradiol levels without supraphysiologic concentrations in the liver. Interestingly, transdermal hormone therapy may have less pronounced effects on hepatic protein synthesis, such as inflammatory markers, markers of coagulation and fibrinolysis, and steroid-binding proteins, while oral hormone therapy has more pronounced hypercoagulant effects and increases synthesis of C-reactive protein and fibrinolytic markers. But that's not all. Both oral and transdermal delivery systems have beneficial effects on high-density lipoprotein cholesterol to low-density lipoprotein cholesterol ratios, with oral coming out on top. However, the transdermal system has more favorable effects on triglycerides. Additionally, incidence of metabolic syndrome and weight gain appears to be slightly lower with a transdermal delivery system. So what about testosterone levels? Well, oral estrogen's significant increase in hepatic sex hormone-binding globulin production actually lowers testosterone availability compared with transdermal delivery, which could have clinically relevant effects on sexual vigor. It's worth noting that while these findings are fascinating, neither results nor study designs are uniform. Nevertheless, understanding the differences between oral and transdermal hormone therapy options is an important step in making informed decisions about your health. Menopause is a natural biological process that signifies the end of a woman's reproductive years, and it comes with its fair share of risk factors, most notably cardiovascular disease and osteoporosis. However, hormone replacement therapy, HRT, in postmenopausal women may reduce or remove this increased risk. But it's important to note that there is a difference in the metabolic impacts that HRT can have, depending on how it is administered. For instance, the high hepatic bolus associated with oral steroid administration can produce unwanted metabolic effects. This is where transdermal administration comes in. By bypassing the liver, this method of HRT avoids the effects that can be caused by oral administration. In fact, a study was conducted on 96 healthy postmenopausal women over 3 years to evaluate the metabolic effects of transdermal HRT in comparison to oral HRT or no treatment. The women were treated with either continuous oral conjugated equine estrogens, 0.625 milligrams daily, with sequential oral DL-norgestrel, 0.15 milligrams daily, for 12 days per month, or continuous transdermal estradiol 17-beta, 0.05 milligrams daily, with sequential transdermal norethindrone acetate, 0.25 milligrams daily, for 14 days per month. Researchers measured bone biochemistry and density, serum lipids, lipoproteins, and apolipoproteins, and glucose, insulin, and C-peptide concentrations following an intravenous glucose bolus. Minimal modeling analyses provided measures of glucose and insulin kinetics. The results showed that both HRT regimens were effective in preventing bone loss and produced favorable lipid and lipoprotein changes. However, progestin addition prevented increases in HDL, 2-cholesterol, but lowered triglycerides. On the other hand, transdermal estrogen lowered triglycerides, whereas oral estrogen increased them. Additionally, oral HRT resulted in a deterioration in glucose tolerance and an overall increase in insulin secretion. In conclusion, transdermal HRT appears to be at least as effective as oral HRT in preventing postmenopausal osteoporosis, and produces as good, if not better, changes in metabolic risk markers for cardiovascular disease. It's essential to weigh the benefits and the potential risks of HRT with a healthcare provider to determine the best method for those considering it. Today we discuss the effectiveness of sublingual and topical hormone replacement therapy for postmenopausal women, the differences between oral and transdermal estrogens and their implications, and the benefits of transdermal hormone replacement therapy for preventing postmenopausal osteoporosis and improving metabolic risk markers. Thanks for listening to today's episode. I'll see you guys at the next one, and don't forget to subscribe. When it comes to assessing hormone delivery and levels in the body, blood spot and saliva tests are commonly used methods known for their accuracy. They provide valuable insights into the effectiveness of various hormone therapies, including oral, topical, vaginal, injectable, and pellet delivery methods. However, it's important to note that saliva testing may not be suitable for evaluating hormone levels in certain specific cases, such as troche or sublingual hormone therapies. Saliva testing works by measuring the levels of hormones that are actively circulating in the saliva. It is a non-invasive and convenient method, often preferred by patients. However, for troche or sublingual hormone therapies, where hormones are directly absorbed through the mucous membranes in the mouth, saliva testing may not provide an accurate representation of the overall hormone exposure in the body. Troches and sublingual medications are designed to deliver high amounts of hormones directly to the salivary glands. This localized delivery can result in a false high determination of the supplemented hormone levels when assessed through saliva testing. The concentrations of hormones in saliva can be significantly higher than what is circulating throughout the rest of the body, potentially leading to misinterpretation of the true hormone levels. In contrast, blood spot testing involves collecting a small sample of blood from a finger prick or other suitable method. It provides a broader perspective on hormone levels in the body, including the systemic circulation. Blood spot testing allows for a more comprehensive assessment of overall hormone exposure, making it a more reliable option for evaluating troche or sublingual hormone therapies. It's important for healthcare providers to be aware of these nuances when selecting the appropriate testing method for monitoring hormone levels in patients undergoing specific hormone therapies. By utilizing the most suitable testing method, accurate assessments can be made, ensuring that patients receive optimal hormone treatment and care.